As a respiratory physiotherapist, we manage respiratory patients holistically, and this involves many aspects of their care, from respiratory assessment, including lung function, sleep and breathing, to ventilatory support, maintenance of range of motion, and improving exercise capacity, helping with continence, and airway clearance. And this slide highlights some of the many skills in critical care above and beyond what I've just highlighted here, which is typical airway clearance. So when we think about the critically ill patient, they may have a depressed cough reflex, an ineffective cough, secretion retention. They may be on positive pressure ventilation, either invasively or via a mask, be dehydrated, and have critical care illness and global muscle weakness, of which I'm not going to talk about the last two today. So thinking of our patient in critical care, they may or may not have an artificial airway and may or may not be on positive pressure ventilation. Both of these factors affect the natural way we breathe and our natural secretion mechanism of the mucociliary clear escalator. The mucociliary escalator beats around 10 to 15 Hz as shown in this video on the left and moves secretions towards the mouth. However, with something as simple as a common cold, as shown here in the right hand video, you saw that secretion clearance was impaired. In addition to this, breathing can also assist in clearance of secretions. Here shows an inhalation. And when we breathe in, the contractible air and flexible airways within the lungs expand. When we breathe out, they contract. The contraction of the airways causes an expiratory airflow bias due to the narrowing and the increase in resistance. And what happens here in this situation is shown nicely in this cartoon. You can see air going past the secretions, and then when they breathe out, the squeezing of the airway moving the secretions towards the mouth. In addition to that, hydration is also key. It's key for enabling the correct viscosity of the secretions, assisting in the depth of the liquid layer. However, dehydration can cause an increase in saliva, and that can further impair secretions due to silent aspiration in this situation. Cough is our primary mechanism for clearing secretions. It has 4 components. You need to have an intact cough reflex and drive from the brain in order to stimulate the cough. The patient will need to take a deep breath in to 85% of their total lung capacity. And you can see this here with the nice inspiratory flow. The glottis needs to close for 0.2 of a second, coupled with a rapid increase of the intra-abdominal and intrathoracic pressure to usually greater than 60 centimetres of water. On contraction of these muscles, the glottis needs to open, and there is a rapid expiratory flow which can be measured as the cough peak flow. The presence of an artificial airway will affect glottic closure, and also the positive pressure and ventilation can help with global weakness, which will affect the ability to increase the inspiratory volume, and that will affect the driving expiratory flows. Let's spend the remainder of the presentation looking at how high flow therapy may be able to help the critically ill patients, and how we can optimise airway clearance techniques with and without ventilatory support as physiotherapists. High flow therapy consists of 2 components. Firstly, high flow, which can be air or air and oxygen. This is set to match the person's peak inspiratory flow rate with just enough oxygenation to maintain a target saturation. The second is the addition of humidification, which should be set to at least 37 degrees for optimal humidification and provide the benefit of hydration to the airways. High flow therapy has 4 main physiological effects: that of oxygenation, decreased work of breathing, lung protection and comfort. And it's the comfort side as physiotherapists that we know can decrease dryness and irritation of the airways and improve mucociliary clearance. Hassani and co-workers found with optimal humidification, there were less secretions present in the airways, and that there was a better bronchial deposition after the humidification that you can see within the black squares in both of the figures. So humidification helps, but what about high flow therapy? This is a table from a review by Stefano Nava's group, who looked at home high flow therapy in patients with chronic respiratory disease. They tabulated all of the studies and the outcomes of the studies, and I've highlighted in blue those studies where they hypothesized that the outcome was a result of the physiological benefit of improved mucociliary clearance, and you can see that that was incorporated into a number of the studies. So in critical care, I do believe that we should be considering high flow therapy in patients with an increased work of breathing and secretion retention who do not necessarily need ventilatory support. But what we have learned is a key target is that we should be aiming for at least 37 degrees to provide optimal humidification. So let's move on to airway clearance and ventilatory support. I've told you that the mucociliary escalator in breathing moves secretions towards the mouth. Physiotherapists can further enhance this by increasing tidal volumes to manipulate breathing to provide a greater expiratory to inspiratory flow bias. Physiotherapists can also use enhanced tidal volumes to overcome the resistance of the collateral channels of ventilation and to open up the airways in order to get behind secretions and move them towards the mouth. In this slide, you can see two examples of how airflow can affect secretion movement. In the diagram on the left here, we have our inspiratory, and this is our inspiratory flow bias versus our expiratory flow bias. And on the right, this is our inspiratory phase and our inspiratory flow bias versus our expiratory flow bias. And it's quite clear that in this example, the inspiratory flow bias is less than the expiratory flow bias and favours secretion movement, whereas this one, the inspiratory flow bias is greater than the expiratory flow bias, and that favours secretion embedment. And you can see the difference in this movement of where the sputum started in green to where it ended up in red between the first and the left-hand side manoeuvre that favoured secretion embedment versus that favours secretion clearance. I'm going to spend the next two slides highlighting that the way patients are ventilated can aid secretion movement. In this study, the authors looked at the effect of ventilation mode, manual chest compression during positive end expiratory pressure and that of zero pressure end expiratory pressure manoeuvres. Patients received this with pressure-controlled ventilation and volume-controlled ventilation. Here you can see the pressure and the flow traces. This is with volume-cycled ventilation and this is with pressure-cycled ventilation. This is the pre-ZEEP manoeuvre and this is the zero PEEP manoeuvre, and the same on the other side. The pressure traces are in dark black for each, and the same pressures are delivered. And this is the flow. This is with volume cycle. The inspiratory flow here is less than the expiratory flow in volumes. However, with pressure, you can see that the inspiratory flow bias is equal or slightly higher than our expiratory flow bias. The study showed and concluded that the expiratory flow bias was significantly higher in volume controlled ventilation mode compared to a pressure controlled ventilation mode, and that we know that this is because there was a lower peak inspiratory flow in the volume controlled mode. When zero PEEP is applied in pressure controlled mode, it didn't affect the peak expiratory to inspiratory flow bias that was generated, and that can potentially cause mucus embedment. Peak expiratory flow in this study was further enhanced by a manual chest compression compared to without, and so this is something that we should potentially also be considering with our patients. So secretion clearance was greatest in this study with volume controlled ventilation, zero PEEP and a manual chest compression. However, for many reasons, pure volume controlled ventilation is not a preferred mode of ventilation in critical care. In the study that was for a 2-hour period, pressure controlled ventilation with a volume guarantee and volume controlled ventilation reduce bronchomucus transport velocity. Here we have the results at baseline, time point 1 and time point 2 hours. We have tidal volumes which are similar throughout the study and peak inspiratory pressures which are lower in the pressure control volume guaranteed group compared to the volume controlled alone. You can see here for the raw data that the pressure control and the volume control that there is a reduce in the bronchial transport velocity, but this is not so much at the second time point of 2 hours. So with a pressure control ventilation with a volume guarantee, it protected the bronchial mucus transport velocity compared to the volume controlled ventilation. And at 2 hours, secretion movement was drastically reduced in the volume controlled ventilation compared to that of the pressure control shown in this figure here. So what we may find is if patients have a secretion issue, we may wish to recommend and consider, in addition to optimal humidification, a pressure control volume guaranteed mode of ventilation. So I've highlighted that ventilation can be used to assist patients in critical care, but what about airway clearance techniques? This figure is from the British Thoracic Society Guidelines for Aspiration Pneumonia, and it strategises therapies and what can be used depending on where the secretions are and whether the patient is fatigued and whether they have bulbar weakness. As you can see here, as physiotherapists, we have lots of options to consider, with proximal airway clearance techniques highlighted in blue and peripheral in red. I don't have time to cover them all, but what I wanted to do was to pick some which may be useful in the critical care environment. In the critical care patient that's weak and fatigued, they will not be able to augment greater tidal volumes that are required to create that expiratory airflow bias, overcome the resistance of the collateral channels of ventilation and move secretions. One option to aid this is providing positive pressure ventilatory support. This can be provided easily via ventilator. However, not all patients need ventilation, and that they may only need it for airway clearance, and in that instance, intermittent positive pressure breathing is an option. Intermittent positive pressure breathing is the maintenance of positive pressure throughout inspiration with the airway pressure returning to atmospheric pressure during expiration. What you're aiming for is an increase in at least 25% in the individual's tidal volume compared to what they can do themselves. In that situation, what you're aiming to do is augment lung expansion, which will recruit collapsed alveoli, and there have been studies showing improved ventilation, improved arterial blood gases if there is a high enough flow rate, and a reduced work of breathing in the relaxed patient. This slide shows the effect of providing ventilatory support in patients with cystic fibrosis for airway clearance. The first figure here shows what happens in children with cystic fibrosis. This is for oxygen saturation, respiratory rate, and heart rate. At the point of the arrows, the patient is performing the forced expiration technique, and without pressure support ventilation, there is a significant reduction in the individual's oxygen saturations after the forced expiratory technique, but saturations are maintained with the addition of pressure support ventilation. This is the whole group data showing an improvement with pressure support ventilation of the mean saturation and a decrease in the respiratory rate. What I haven't shown here is that there was also an improvement in the respiratory muscle strength, showing that ventilatory support in this group of patients offload the work of breathing. This was also shown by Anne Holland in adult patients with cystic fibrosis. Again, they had improvements in respiratory muscle strength, but they also had improvements with non-invasive ventilation in the mean oxygen saturation, the minimum oxygen saturation, and the percentage of time that the patient was receiving an oxygen saturation of less than 90% was less in the non-invasive ventilatory support group. But does it actually move secretions? In this final graph that I'm showing you here, they looked at the lung clearance index, and with bi-level ventilatory support after treatment, the lung clearance index showed an improvement in secretions. When manual techniques are not enough to clear secretions, high-frequency chest wall compression is another addition that can be added in addition to ventilatory support. High-frequency chest wall oscillation can be used to mobilise secretions, but also has the ability to provide ventilatory support. The oscillations in both of the techniques have the effect of potentially enhancing the mucociliary escalator via the flow interruption, and that can provide a mini cough phenomenon, enhancing secretion movement. In this meta-analysis of high-frequency chest wall oscillation on acute exacerbations of COPD, they suggest that the use of it may have the advantage of increasing sputum clearance and effectiveness and decreasing length of hospital stay in acute exacerbations of COPD. Here we have a forest plot showing high-frequency chest wall oscillation versus a control group for treatment time and secretion production, and you can see that it clearly favours high-frequency chest wall oscillation. In this one, when we look at high-frequency chest wall oscillation versus control for hospital length of stay, it also favours the use of high-frequency chest wall oscillation. And this one, compared to treatments of oscillatory PEP, there was an increase also in the secretion production with high-frequency chest wall oscillation. However, as with all meta-analyses, we should highlight that these findings should be taken with caution because there was a wide degree of heterogeneity amongst the study. This study shows that both high-frequency chest wall oscillation and intrapulmonary percussive ventilation can improve lung function, muscle strength, dyspnea scores, and also health status. But intrapulmonary percussive ventilation demonstrated a greater effectiveness at improving results linked to small bronchial airways and alveolar ventilation and muscle strength, as well as activities of daily life compared to that of high-frequency chest wall oscillation. Both techniques were considered comfortable, that they were easy to use, and that they were convenient. So, if you have the choice between high-frequency chest wall oscillation and intrapulmonary percussive ventilation for the critically ill patient, it may be more effective to use IPV to clear secretions. So I've highlighted choices for mobilising secretions towards the upper airway, but what do we do if the patient is weak and has an impaired cough? In this survey from the Netherlands on which techniques are used within the intensive care environment, mechanical insufflation exsufflation, shown by this top line, is never used or used only on indication. And I agree, I don't believe that MIE should be used in every patient in critical care. It certainly has its place. MIE is easy to set up and it can be used in the critical care environment either via an artificial airway or a mask, and typically can be used with symmetrical pressures, and by this I mean like demonstrated in this example, starting at +20, -20 and building up as the patient requires it. What final settings a patient will require would depend on various factors, how weak they are, and also whether there is the presence of an artificial airway. This study shows that for the same settings, the peak expiratory flow rates generated with an MIE device via an endotracheal tube or a face mask are different. Individuals that are receiving MIE via a face mask will generate for the same settings a significantly higher peak expiratory flow rate. This is it shown here graphically. This in black in the endotracheal tube and this in grey for the face mask for various different settings. One explanation for this is that with the artificial airway, there will be an increase in resistance, and it also prevents glottic closure, which is an essential part of the cough reflex. So clinically, we need to reassess and change settings dependent on our patients and their status and their airway. Removal of an ET tube will decrease resistance and will also allow the glottis to close and enhance expiratory flow at lower settings. So if you're continuing to use MIE, once the tube has been removed, you may find that you're able to decrease the pressure settings. However, some patients in critical care cannot tolerate high pressures, and an alternative way of helping with this could be to change the rise time on the mechanical insufflation-exsufflation device. This study nicely shows a standard MIE setting with a high rise time, as you can see here on the pressure, versus a ramped or a reduced rise time, again shown here on the pressure. Changing the rise time changes the flows. You can see here the inspiratory flow and the expiratory flow with the standard settings of the high rise time, versus a lower inspiratory flow when you reduce the rise time, giving a greater difference in your peak inspiratory flow to your peak expiratory flow bias. This results then in a normal scenario enhanced secretion movement compared to a high rise time, and you'd see the same in a restricted patient. The lower the rise time, the more secretions that are moved because you have a greater expiratory flow bias. Studies using standard settings of +40 and -40 in the intensive care environment have shown an increase in sputum production when mechanical insufflation-exsufflation is used, and improvements in lung compliance. I already highlighted that a manual expiratory ribcage compression with ventilatory support enhances expiratory flows, but using this in addition to mechanical insufflation-exsufflation here highlighted in blue further enhances secretion production compared to an external ribcage compression alone. And what we also see with external ribcage compression with the addition of mechanical insufflation-exsufflation, an improve in the respiratory system compliance, and heart rate is stable throughout. Gas exchange improves similarly between both manoeuvres. In this recent study looking at mechanical insufflation-exsufflation in preventing extubation failure, there was no difference between the controlled group and the mechanical insufflation-exsufflation group for outcomes. However, the mechanical insufflation-exsufflation group required significantly less suction. And we know that from patients with spinal cord injury, when you ask them about suction versus mechanical insufflation-exsufflation, they found that mechanical insufflation-exsufflation was less painful, less irritating, less uncomfortable. And when they were asked what technique they would prefer in the future, they would prefer mechanical insufflation-exsufflation more than suctioning. A key area in critical care is ALS patients that come in with a respiratory decompromise due to respiratory tract infection. And this is a flow algorithm that we developed with Tina Anderson, Nicole Shears and myself about optimal titration of MIE in ALS patients. This is a group of patients where standard settings of +40 and -40 are likely to be ineffective, especially in the bulbar patient. What we recommend is that when looking at the insufflation, that the patient's trigger is turned on, that the pressures are started low between 10 or 15 centimetres of water or the same as their non-invasive ventilation setting, that the rise time is high in non-bulbar and low in bulbar, and that you should start an insufflation time of 1.5 to 2.5 seconds. As with all techniques, look for a good rise and fall, ensure that there's sufficient volumes. A key thing with these patients is to instruct and encourage that the patient coordinates glottic closure with the pressure swing. The exsufflation pressures, if you don't know what to start with, around 15 to 20 or slightly more negative than what you've previously set as the positive pressure, and that you look for an exsufflation time of 1 to 2 seconds. Assessment can occur by cervical auscultation, looking at flow volume, flow curve detection, ultrasound at the point of bedside, or nasal endoscopy. It's really important with these patients that we do optimally titrate them and that we look for efficacy, because mechanical insufflation and exsufflation in this group can make a significant difference. So my take-home message with regards to airway clearance techniques and ventilation is that ventilation strategies can assist in secretion movement. Patients that are fatigued should have ventilatory support, and high-frequency chest wall oscillation, or IPV, might be useful in patients with an acute exacerbation with excess secretions that current conventional therapy techniques are ineffective for. Mechanical insufflation and exsufflation should be used in certain patients in critical care. Patients with artificial tubes will need higher pressures than those without. Standard settings built up to +40, -40, where indicated, for example, is a useful approach. In patients that don't tolerate high pressures, consider manipulation of the rise time and look to individualise your approach in the management of bulbar patients. So I'd like to thank you for your attention and hope that this lecture has been helpful to your practice. Thank you.